ask. Thank you, Amy. If you could put your name and your organization and your title in the chat, so we do have a record of that. We'll go ahead and kick it off. I know we all have busy schedules and lives, but I'm so thrilled that you're here. I am Becky Betts, and I am Chief Operating Officer for Greater Health Now. I am thrilled to be with you today for the launch of our primary care transformation model pilot project. I recognize many of your names and faces, and I've had the pleasure of partnering with you in a different capacity. In January, I left Providence Health System in Walla Walla after 32 years of service. And during my tenure, I had the pleasure of overseeing 3 practice transformation sites that were, sponsored and run by Greater Columbia ACH, which is now Greater Health Now. And of course, the MTP, or the Medicaid Transformation Project Waiver 1.0, did end, as we all know, last December. And we've all been waiting for Waiver 2.0, which was signed on June 30th. I'll talk about more of that in a minute. But I was so delighted when I came over to Greater Health Now and realized that Greater Health Now really committed to practice transformation. We got an awful good start during that 5-year, 6-year with that extended year, doing those milestones and moving the needle in more of a team-based concept. But we had a lot of challenges during that waiver period. We had unprecedented staffing and workforce issues. We had a little thing called a COVID pandemic, which took us out on our knees, and just, a lot of challenges. Many of our clinics were not quite ready for true integration. So I was excited to see that Greater Health Now was so committed to that work for the first, that it wasn't going away, that they had earmarked and budgeted funds allocated out of waiver funding to continue to do a pilot for 2024. We are the only accountable community of health that is continuing this work. This is very exciting. This has the attention of the Healthcare Authority and our managed care organizations. They'll be watching this pilot with bated breath. And of course, hot off the press, we couldn't have planned it any better, was the CMS Innovation Center releasing Make Care Primary, which I think some of your clinics are going to go for. So this really dovetails very nicely and crosswalks, and you will have a subject matter expert walking you through this in Laurel that can help align those projects. But like I said a minute ago, the Waiver 2.0 was signed. We do have another 5 years of waiver funding coming at you. Much of the details is still left unknown. We're waiting on the special terms and conditions. But what is a little different this time around is that the Healthcare Authority and CMS has mandated that our accountable communities of health become a regional care coordination hub. So that has been a great deal of my time and effort the last 10 months, is to really be thoughtful how we develop a hub that works for 9 counties, population of over 750,000. 1 out of every 3 of our lives are covered by Medicaid. How we want to do this and move forward. So more to come. I'm going to put my name and my phone number and my email in the chat. I know some of you have been anxious to find out more details, but I truly believe, as my colleagues here at Greater Health Now, that we are only as strong of a hub as we are of the clinical community linkages we create within that hub. And we have to figure out how to put it all together. A large emphasis of the next waiver is around supporting community capacity, community-based workforce, community-based organizations. But we have to figure out and weave those traditional health delivery systems and the good work and the investments that you guys have made in your own infrastructure. So without further ado, I want to get to the content of today, and I am thrilled to introduce you to Laurel Avila. She is a superstar, and I had the pleasure, like many of you, working with her during the last waiver. And when we started talking about this pilot, I immediately was like, we got to have Laurel, we got to bring Laurel back. And she was not with our organization at the time, but we brought her back to the team as a contracted nurse specifically for this project. So in other words, she's yours. She's committed to you, and she's committed to your success. And boy, did we ever hit the right person with all of the bells and whistles and expertise. So without further ado, I'm going to let Laurel take over for the bulk of the programming. We will have time for Q&A, or feel free, but if you do have a burning question, it's really important, please type it in the chat so we can prepare for that and address it when Laurel has a pause during her presentation. Laurel, are you ready?
I'm ready. Thank you so much, Becky. It's so great to see everyone here, and I am delighted to be here as part of this work. I've been on both sides of the transformation work as a practice transformation navigator with Greater Columbia ACH, and now coming on board with Greater Health Now. I also worked with practice transformation at Lours as the clinic director for primary care. So I see some friends out there from that time of my work history. Go ahead and get rolling here with our presentation. So I'm also a patient-centered medical home certified content expert. And as you know, much of this work you guys are doing, some of you are already recognized as a PCMH home. So I'm excited to have that background to help with this project. And I am excited to be here. I'm excited to be working with you all. For today, we're gonna just focus in on this practice, I'm still calling it practice transformation at times, primary care transformation model. The model was developed as a healthcare authority in collaboration with the state's payers and primary care communities. So there were two work groups giving feedback and helping with building this model that we're piloting here as part of this work with Greater Health Now. And there's a lot of information that's actually out there on the web. So I'm gonna go ahead and ask Amy to drop a link in the chat for you all. And this link will be able to send you right to be able to look at the model and some background information and the journey that has been going on leading up to this point of our pilot. So I welcome you to look at that for more information. And the goals with this pilot are to help the clinics that are going to be participating with us to succeed in alternative payment models. So just some of you are already taking advantage of this, of getting some funding with your transformation efforts for quality payments and for comprehensive care payments. Also, we would like to help you to enhance your team-based care. We really do believe, and this model really focuses on that aspect of team-based care, and we'll hear a little bit more about that as we go on into this presentation. Also, developing a care coordination strategy that leverages partnerships with community-based organizations. So important in trying to help us help our patients, especially those who have health-related social needs. And so really that partnership, we want to, that part of the goals of this program is to help with developing those partnerships and linking you up with that. And also positioning clinics that are looking to achieve PCMH recognition. These activities align very well with that, and we would like to do that. And I know some of the organizations in the audience today already are PCMH recognized, so to be able to continue in that effort. So I'm going to go ahead and move on to an overview of the primary care transformation model. The model has 10 accountabilities, and then within that there's 3 levels of achievement. So first we're going to go into all 10 accountabilities, and I will go ahead and do that. So the first area is whole person care. So the practice is accountable for providing or ensuring access to a full range of primary care services to attributed patients. So that's just providing the care that you have, the services that are sufficient to address the full spectrum of care to meet the needs of your patients. Straightforward things, minor illnesses, caring for injuries, chronic disease management, the preventative services, office-based procedures and diagnostic tests, and low complexity behavioral health interventions. And we've worked hard on that during practice transformation to have be able to address that. And we have a whole area of accountability in the model here that deals more in depth with the behavioral health integration into primary care. The second area is a team for every patient. So, and going through all these accountabilities, I'm not giving you like the detail of all of the competencies that you would need to complete or demonstrate competency in. Just trying to get you an idea of what we're talking about when we're talking about each of the 10 areas of accountability. So the second area is a team for every patient. So attributed patients are assigned to a primary care team. They're impaneled for evaluation, treatment, and ongoing management. The primary care team may or may not reside in the same physical setting and doesn't need to have the same organizational affiliation to act as a team. So when we're looking at empanelment, it's the place that we would like to see, and many of you already do this, I know, but your patients are known to your care team and your care team known by your patients. So you have that relationship of trust. And then care team should be consistent.
I did not.
So, we might need to have everybody take a quick peek and see if they're muted. Care teams should be consistently leveraging morning huddles and chart prep and other team-based activities to enhance the patient care. The resource allocation strategy. So practice has and uses a documented strategy to prioritize resource use across all empaneled patients. The strategy includes addressing medical need, behavioral health diagnosis, and health-related social needs. So here's where we are looking to see a risk stratification tool, and that there will be care management being performed, and then follow-up for hospital admissions and ER visits. All of this should be sounding quite familiar to you. Behavioral and health integration. So there's the assessment tool that we're going to use for seeing if you've met competency for the levels in behavioral health integration is the Washington State Integrated Care Assessment for Primary Care Settings. That's the Washington ICA. And again, what would be helpful for you is to be able to review the tool, and it's out on the web. So I'm going to ask Amy to please go ahead and drop the link in for that as well, so that you can learn more and more specifics about the tool. But basically, the tool, it is assessing how we're doing screening, referral to care, and follow-up for depression, anxiety in the primary care setting. We're looking for evidence-based care that is used in treating any patients who have tested positive for your screening tool. And then also looking at the use of psychiatric medications. Things we would like to see are that you're not only, as you're prescribing, but looking at evaluating how the patient is doing with follow-up, and then also coordinating where it's possible or where you may have partnerships in place with psychiatrists as part of your team to evaluate and get advice on how to manage your patients that are being medicated with psychiatric medications. So really an important part is that information exchange among providers, and with even if you are so fortunate to have a behavioral health specialist embedded in your team. I'm going to pause here and see if there are any questions on the areas that I have covered so far. And I haven't seen anything come in the chat. So we'll just go ahead and move on. So the fifth area of accountability as part of this pilot model is patient support. So we're ensuring that patient goals, preferences and needs are integrated into care, and patients have access to self-management tools. So are patient surveys being done? Are there focus groups where patients have an opportunity to have their voice heard and contribute their valuable feedback into the care that they're receiving? Are we using decision aids or self-management support tools to, again, incorporate that patient voice into the care and engage them? The care coordination strategy accountability area, the practice coordinates care to minimize gaps in care, ensure patients are connected to referral resources, and ensure general continuity of resources. I know how difficult this one is from my days as a clinic director, but things that are part of this accountability is the things like when we're referring out to specialty care, are there individualized clinical summaries for your patients that you're referring? When patients have been referred out and has medication reconciliation been done when they come back in case there's any new medications or things that you may not be aware of, helping the patients understand what those medications are if needed. And also, are there community resource referrals being done? And even in the higher levels, so 1, 2, and 3 levels that we'll talk about in a moment, even potentially tracking for those patients that have been sent out for community resources via referral. How did that happen? And is that patient getting the help that they need? Are there care plans for patients? And are there care compacts in place with specialty providers? So all of this care coordination, so important, and that's that 6th area of accountability. So the expanded access accountability is looking at is a practice offering same-day appointments for routine and urgent needs. Are evening and weekend hours offered? Is there an ability to provide 24/7 clinical advice, telephonic access, community IT innovations, and access? The expanded access, is that provided for both physical and behavioral health? So with this, there is an opportunity to just give information about how you are doing these things. Are appointments available outside of the normal Monday through Friday 8 to 5 time frame? And do you have the ability to provide urgent care needs within your schedules for on a daily basis? So it just pretty self-explanatory on this area, but that's expanded access. The 8th area is something that is being focused on a little more in this pilot than what we were doing back in practice transformation, although we had it. The practice provides culturally supportive care in location, language, and demographic composition. So you need to know your patient population and knowing them, what are the top 3 languages that are not English that are part of your patient population's need for communication. And is there real-time interpretation available for those top 3 languages? Is there consideration for patient demographics as part of quality improvement? And is the care culturally appropriate? And are we partnering? Sometimes it's very helpful to partner with community-based organizations to help our staff and team get more information about how to provide that culturally attuned care. Okay. The 9th area is health literacy. So we're looking for patient-facing forms and information that's accessible for a diverse population. So are your forms not only available, but are they written at an appropriate 5th grade reading level for your patient population? And also in languages are reflective of the patient population. And the last one, they saved the best for last here on our model. a data-informed performance management. This one can also sometimes be the trickiest to get that data out and available. But for this area of accountability, the practice builds capacity to query and use data to support clinical processes, population health, and business decisions that result in improved quality and financial performance. So being able to electronically send and receive data regarding attribution, care coordination, and performance to, as well as from, health plans, and incorporating data into improving workflows. Do you have an identified process improvement model that's consistently used? And are you able to measure and track physical and behavioral health outcomes? So that's a lot. I'm going to pause and see if there are any questions on the 10 areas of accountability. Hopefully it's pretty straightforward. I'm not seeing anything, so we'll go ahead and move forward. The 3 levels of achievement, just very basically, I mean, there are specific level criteria within the accountabilities and within each competency in the accountabilities. But level 1 is that you are meeting minimum participation standards and working toward transformation. So there's a statement that's part of our model, and it says, and I quote, "Practice can demonstrate they have the following competencies or have a robust strategy for implementing the accountability in the next year." So if you saw anything that looked like a stretch for your organization as we went through those 10 accountabilities, that would be our opportunity to develop some kind of a quality improvement plan, and then that would be able to meet the level 1 competency to be moving forward towards transformation. Level 2 is making progress towards transformation, and level 3 is that you're implementing the model with fidelity. So okay, and so that brings us to our participation requirements. The requirements are very straightforward. So completing quarterly reporting, and I'm going to provide a little more information about what that looks like in the slides to come. And actively participate in monthly shared learning webinars. So they'll be once a month during the whole run of the pilot. And I think I haven't mentioned up to this point, but we're planning on running the pilot beginning in January of 2024 and running for the calendar year. So that would be, there would be the 4 quarters. And so each quarter there would be 3 webinars, and 2 would be the requirement for attending to meet participation requirements. And then meeting with me monthly, just hopefully with your quality improvement teams. It can be more often than that, but the minimum requirement would be to meet with me monthly, just to get information about how it's going, and provide any technical assistance for coming up with goals or how to meet them, or working with your teams, providing education, those types of things. So the incentive allocation that's available for the participants in the pilot are here. And what you see is for completing the 3 areas that need to be completed are the reporting, meeting with myself 3 times per quarter minimally, and attending 2 shared learning webinars minimally. So with that, as you see, that would be a payment of $20,000 per quarter for a total of $80,000. And there's some bonus opportunities. So as you're participating in this transformation effort and you're moving from level 1 to level 2, there's an opportunity for a bonus, and for level 2 to level 3. We also really believe that formal agreements with community-based organizations would be very helpful for your organization to move forward and addressing some of those health-related social needs that are so important for the overall health of the patients that you serve. So that is also a part of the incentive allocation. So the reporting schedule, so there are the 4 quarters listed as you would expect, January through March and so on. The reporting due date follows pretty much it's 30 days following the end of the quarters, and then expecting payment another with 30 days to follow that. Amy, do we have any questions in the chat?
I am not seeing any.
Okay. All right. And we will have a chance for questions at the end. You guys are saving up. We will be using a reporting portal for demonstrating competency and the 10 areas of accountability. I just have a quick little screenshot here. I will say this, I can demonstrate if we have time at the end of our presentation. I can share my screen and demonstrate what it looks like. It's pretty simple and straightforward, but it is accessing the portal and putting in the information that is needed there. I've gotten some questions as I've met with some of you and individually in your teams. And I know that it would be good to know as much as possible up front, well, what are some of those data requirements? So we've tried to make things pretty straightforward with the requirements for data reporting, but these are the requirements that are part of the pilot. So an accountability 3, level 1 and C is number of hospitalization notifications that you received, and also the number of patients that have been scheduled for follow-up after hospitalization. And I know a lot of you are already getting this information, and that's the way we like it. We don't want you doing different. One of the goals is alignment of processes so that you're not doing different things for different organizations. The second one is the number of ED visit notifications, and then the number of patients that were scheduled for follow-up after an ED visit. There's also the number of patients that are identified in need of care management, care coordination, or closure and gaps of care. And then another data point is the number of patients that received that care during that time frame of reporting. And the last one is the number of patients identified for medication reconciliation after engagement with those referral specialty providers or other care. And then the number of med recs that were actually conducted. So, and this is more of a medication reconciliation that is taking time to make sure not only what the medications are, but that they understand them, they are taking them on schedule, that type of thing. So I will pause here, and there's a question, it looks like, coming in the chat. Is just TCM eligible hospitalizations, or does this include planned elective? And so, yeah, so this is just for the TCM eligible, so the non-planned hospitalizations. Thank you for the question.
And this is Kim. Can I just ask a question?
Sure. Hi, Kim. Yes.
Hi. So for the number of follow-up on EDs, is that they have an actual visit, or that we reach them by phone? Because some people don't feel like they need to come in and don't want to come in, but we do call every single person. So what does this mean?
Yes, then that's the case. So just a follow-up, whether it's telephonic or if it's payment for a visit.
Thank you.
You're welcome. Okay, so there are those specific data points, but the other types of things that will be required for reporting, there's a lot. Provide a narrative explanation. So how are you doing it? Explain to me your processes, just so that we're able to understand. Or there's also many opportunities to upload a document or a workflow diagram. So how are you doing that? So if you have what's your referral process, and how are you tracking that? And if you're following up for patients that have screened positive for depression, what does that look like? How are you following up? And after they've engaged perhaps with your embedded behavioral health provider, but they haven't been there in 3 months, what is your process for tracking that? And what is the process for follow-up? So whatever you have that you're using, there's opportunities to provide narratives, upload documents or workflow diagrams, or you can even use a screenshot from your EMR with your patient information redacted. And also, since I will be out with you all meeting, there's opportunities that you can not have to do all of that work and just demonstrate for me during our time together how you're doing it, and that will help you meet that area of competency. So hopefully that makes sense to you all. Okay, and I can see the chat here, so I'm looking, and there's a question. Does it count if we find evidence that they followed up with a specialist? Yes, yes. So they had an ER visit for a kidney stone, so followed up with urology. Absolutely, because you all know better than me where you're out there and doing this work. Those patients definitely need that to have some type of follow-up to just say, yes, I understand my medications. I'm back in the care of my primary care physician, and just kind of making sure that they're okay. If there's anything that they need, do they need to come in for a visit? And that particularly with that med rec, so important, has really been so helpful with patients. I was recently looking at the studies of how important it is to have just that visit with an RN, the care coordination piece, and help them have a place to ask questions that they may not have thought of at the time of discharge or at their visit, but they have that trusted relationship with their care team. And so then the questions come, and that will help us prevent any untoward outcomes, rehospitalizations, or unnecessary ER visits. So important, the work that you're doing out there. Okay, I have such a quiet group. We're just plugging along here. The next steps for you and your clinic, if you would like to participate with us in this pilot, is to submit an interest in participation form online by 10/13/23. So we have on our website, and I will go ahead and ask Amy to drop that into the chat as well. The Greater Health Now website has a resources tab, and you click on that, and under the resources tab, you'll see Washington State Primary Care Transformation Model Pilot. And within that, you'll see the form that you'd fill out. You'll download it. It's a fillable form, and then email it to me. So the instructions are there, and we need those forms.
Progress.
And a contract package will be sent out mid-October to the 10 clinics that will be participating with us. And then completed contracts will be due back mid-November. And then the last step would be arranging meetings with me and beginning the pilot in January. So, so important to kind of keep these dates in mind. I know your teams so need to have forewarning because they're already really busy, and would like this to be a chance for you to prepare people, explain to people, loop me in, and if you need for me to speak with your team, your staff, to help them understand the project more and why we're doing it. Really the most success we're going to see is when we have champions, and at different levels. If we have a physician champion, if we have a medical assistant champion, who understand and know and have the goals in mind with this and have that ready to go by the 1st of January, that's just the best scenario. So I am going to go ahead and open it up for questions. I don't think we have any more in the chat, but if you at this time, we can go ahead and open it up. So if you just want to unmute yourself and ask questions or raise your hand, and we'll recognize you, and we can go ahead and have more of a interactive question and answer.
Laurel, can you hear us?
Yes.
This is Sarah at Lord's. I'm in the conference room with our practice transformation team, and we had a question about the ER follow-ups.
Okay.
Is it a requirement that we call every single one of our patients after they present to the emergency room? Because we've got over 400 patients that go a month, and so we created a triage system. Over 500 that go to the ER a month. So we've created a triage system of who we focus our follow-up calls for.
Yeah, so Sarah, that's exactly what we're looking for in this model. Is what you said is you have a process for prioritization of who you call. Yeah, because we don't have enough staff to call all of those people, so that you have a process in place, and that you're able, really, there's not a, in this pilot, it's not like, oh, you have to get 75% of your calls. You have to show that you've done that in order to get credit for that, and then, or payment. It's not set up that way. It's set up to show, okay, you know, this is really just wanting to help clinics get their processes in place, and that they are looking at their numbers. And so, you know, that what you're explaining here does meet the criterion for that. And that you would be able to report the numbers of patients that you did contact post ER visit.
Excellent, thank you.
Yeah, thanks. Good question. Yeah, thank you, Sarah. Well, I hope it is that clear for you guys, that you don't have any other questions. Let me give you my contact information. And I know I've reached out to most of you already, so you hopefully have my email, but here it is. And you're welcome to call my cell as well if you prefer that, or to text. And if we need to schedule some time to get together, that's certainly available to you as well. Really looking forward to this opportunity to work with you. Hi, Mike. Yes, we will be able to send out the presentation. We will have a recording of the presentation, and then I can send out the slide deck in an email for the people who are in attendance here. Okay, well, I get to give you the best thing of all today, is just some time back into your day. So I hope that you guys are all doing well, and I look forward to hearing from you. So take care, and we'll see you soon.
Laurel, thanks very much. Thank you.
Thanks,
Thanks,
Laurel.
Dr.
See you later.
Okay, bye-bye.